So today's July 27th. It's second to the last day for us to be here in the Seattle area. We are now headed out onto the Puget Sound to an island where Heidi is a physician practicing house calls. She used to have a clinic but closed it in 2019 and now does house calls only. She's the daughter of a physician who did house calls, and so that's part of the story we also want to capture. But just get a chance to meet with her, sit down, maybe have some tea, and chat a little bit, share some stories, experiences. She'll have some unique perspectives because she is an older physician, but also a female physician. So we'll be able to get a chance to discover a little bit more what it was like her as a young female physician. I suspect, as an older physician, she'll have a lot more philosophy about how she is as a physician and what she does. Older physicians, once they've gotten to this stage, they certainly have lots of experiences and lots of knowledge, and with age comes wisdom. And it would be a shame to not get some of the pearls of wisdom that she has and share it with people. I think that's what we'll be losing as these older physicians retire or move on or stop practicing. So right now we are on Whidbey Island, and obviously this is more rural. Being a city boy in Washington, D.C., I can zip around and the population is dense. Here, everything's more spread out, so the logistics become an issue. So it'll be interesting to hear from Heidi what it's like, how many patients she can see in a day, if there's an urgent need, how quickly she can get to people. What to do about emergencies, how to get them off the island onto another hospital on mainland. That's going to be extremely important. For me, I'll throw a patient in the car and head on out to the hospital. That's going to be different. You may have to throw somebody on a plane, one of these puddle skippers, and get him in and get him out. So there definitely will be a different approach, same philosophy. But I would say just every place is going to have its own unique habits or traits.
Okay, because that means that's why the cameras are here, so we can just cut to another angle. And in the edit, it's like
never happened.
So,
it's wonderful.
Okay, good.
If I pick my nose, I won't say.
Alrighty, so everything is going, and audio's rolling, so we're all synced up, and you can carry on.
All right.
So we'll start with the name and location and profession, and then dive in.
My name is Heidi Rendall. We're in Freeland, Washington, which is on Whidbey Island. I'm a family physician, primary care. I now just do home visits. I don't have an office practice, and operate out of my home.
Fantastic.
So, give me a little bit more history. Where are you from originally, and family? Any other stories you want to relate so that viewers kind of get a sense of how you got here?
I grew up outside Boston. My family is my parents and my twin brother, David, who actually is a PA in cardiology at Duke now.
Excellent.
And we lived outside Boston and went to Maine in the summers. And I went to school in the East. After college, even though I'd been pre-med, I decided to take a little time off and make sure that I wanted to continue going to school.
Of course.
And moved out to Berkeley, California, where I had some friends, and actually thought I might be a professional musician.
Really?
Rather than go on to school.
I didn't know that. That's fantastic.
I played the violin when I was young.
Wow.
And played reasonably well.
Okay.
Played in the Boston Youth Symphony.
Okay.
And through college and took lessons. And my teacher wanted me to go on to music, but I went one summer to a music school where they had a summer camp, one of Juilliard's schools in Maine, in Blue Hill. And I was accepted just because I was a day student. I clearly wasn't a prodigy like most of the people there. But I began to realize that that's their whole life. And I mean, it was music 24/7. And I just had too many other things I wanted to explore.
Yeah, at that age, yeah.
Right,
certainly.
so I sort of let that go. But then after college, I thought, well, maybe I could make it. And I did play quite a bit of music, but I couldn't get any jobs really consistently playing music. And had a bunch of different jobs. My first job, I was a vegetarian, and I got a job at Sam's Gigantic Burgers on Telegraph Ave. 3 hours a day, mostly washing dishes. And after a month, I got a real job. And I'd actually talked the owner into closing on Christmas Day because I had convinced him that he was going to lose more money by staying open than, and paying all his employees, because nobody was going to come on Christmas. So the other employees were just my best friend after that. And then I got a job, and they said, you're really smart, you should finish school. I said, well, I did finish school. They said, you should go to college. I said, I did go to college. They said, well, you didn't put that on your resume. Well, everybody told me I wouldn't get a job if I put that I'd gone to college, and I needed a job. So then I had a job working with children who didn't have, in foster care basically, but it was a Roman Catholic orphanage in San Francisco.
Oh, wow.
And
this is back in the 70s.
Right.
Wow, okay.
And so I really loved the kids.
Yeah.
But my boss was a nun who was pretty rigid. And she pretty much left me alone. And so I could really deal with the kids. And I enjoyed that. But then she retired, and a younger person came to take her place. And she was much more rigid. And I was a vegetarian. And my hours were from like 1 to 9 at night. So I had to eat dinner there. And so I said, well, I'll eat the vegetables and fruit, but I'm not eating meat or fish. And because I wouldn't say it was for religious reasons, she gave me a really hard time. And it was she was either going to fire me by being a bad example to the kids for not eating everything on my plate. So I resigned, and then I filed for unemployment. And the head psychologist there went to court with me to back me up, saying I wasn't a troublemaker. So I got unemployment, and then I decided I better go back to school. And I was fortunate to get into Berkeley in the nutrition department. And I explained that I've been working with teenagers, and nutrition was really important, an important part of health, and did that for a year so that I could take science courses. They said, we don't care what you learn, but you got to get A's in science. At Princeton, everything, well, my major was pass-fail. I did take science courses and did well, but it was sort of a different scale. I didn't get an A in everything. Whereas on the West Coast, if you just were at the top of the class, you'd get an A.
Ah, I see.
And so I did that for a year, and then I applied, and then I worked in a lab just doing computer inputting for a year, and then I got into to school at UC Berkeley.
Berkeley.
That was a 2-year program, hopefully a feeder into San Francisco, but also becoming an independent medical school in the Bay Area. But with politics, they finally decided they didn't want 2 medical schools in the Bay Area.
Ah, I see. Okay.
So they developed an extra year at Berkeley for more public health, and then you would go to UCSF.
I see.
But they hadn't developed that yet, so I just went to UCSF.
I see. I see. Okay. Excellent.
And then I got into the family practice program there, did my internship and 1 year of residency, and left at the end of that year just because I felt that I wasn't learning what I wanted to learn. I was spending a lot of time doing really care for patients, basic care, like getting them a meal, doing all the labs, and then if you wanted to make sure that if you did a spinal tap or a blood gas, if you didn't take it yourself to the lab, then it would get lost. And then you'd have to do it again, and that wasn't good for the patient. But the lab was way down in the cellar, and I mean a labyrinth, you know, traveling around in the middle of the night. So it was, I began to feel that I wasn't learning what I needed to, and I had a couple experiences, one in the orthopedics, because we rotated through everybody else's departments. Where
that's what we do still.
I was told to admit someone who had a broken hip. And so I admitted that person, and then I went to the radiologist because the note said the right hip and the patient said the left hip. And I thought, I better find out what it is. So I went to the radiologist in the ER who I knew from working there, and he said, they shouldn't have admitted that patient. I told them it wasn't a fracture. So I didn't get any more imaging, and I planned to discharge him the next day, and I got in a lot of trouble for that. And another one, I was supposed to go get a CAT scan on someone who might have a cervical fracture and hold him, and I said, I don't really know how to do that. And so I called my resident, would you show me? And no, he was busy in surgery. So I didn't do it. And I called again in the afternoon, would you do it? No. So then around 6 at night, and I wasn't on call that day, I got told to scrub in for surgery and hold retractors for hours.
It's your punishment.
As my punishment.
So you kind of set the stage for who you are as a physician now based on being an independent, really.
Right.
You have to go with what you feel is right, and you do it what's right for the patient, not what's right for anything but the patient, you know. So, but tell me a little bit more about your family growing up. I understand your father was a physician too.
Yes, he was an internist. So he had his own small practice in the town, and he shared call with a couple other independent doctors. And they had he had like a little office there was a central waiting room, and then he had one room where he had his desk, and then a little room where he had an exam table and a little lab and stuff. So I can remember going down, you know, at off hours with him and just kind of hanging out and listening to dictate. And occasionally, I can't remember exactly when it was, but I must have been 10 or 12. One Saturday, maybe we were going to do something, but he had to do a house call. So I went with him and just sat in the kitchen of the home that we went to while he went in to see the patient, and spent maybe half an hour or so, and then we went on and did something else. And so it was just kind of second nature.
That's fascinating. I've taken my son on house calls occasionally. I don't think he really likes to do that anymore. I think one time the patient was actively nauseous, and my son, now I'm not doing that anymore. But so in your father's practice, and you're experiencing that through you are a physician, and your brother is a PA as well, and Duke. So it definitely left an impact. Did your father, was he independent? Did he work in a hospital, or he?
He was independent. He was on the staff at the local hospital, and he was involved. He taught at Harvard second-year medical students.
Okay.
Clinical rotation, so he had like 6 students or
Yeah.
however many. So he did that for many years.
Okay.
And he also worked, I'm trying to think, he was involved with the Mass General. He sent patients there. He didn't have an office and he wasn't really employed by them,
Sure,
but
sure.
he knew a lot of the people
Yeah,
there
yeah.
and was involved there. And
Okay.
later in his life, when he retired and moved to Maine, he was involved in setting up a referral system for a lot of the people from Maine, and he even drove them down,
Really?
some of them who needed special care
I see.
when it wasn't really available locally.
Oh, yeah.
You know, everybody would call my dad and say, "What do you think?" And my dad would say, "Well, maybe we should get a second opinion." And he'd get them hooked up with someone, and he'd get them down there. And I remember when I went back in maybe 2005, a lot of the people that I'd known when I was a kid came up to me and said, "Let me tell you about the time your dad saved my life."
Really? Wow.
Even after he wasn't in practice, people were always calling him. And he was a very good diagnostician.
Okay.
So he always managed to figure stuff out or say, "Let's think about this again."
Exactly, yeah. It's listening, but it's also, I always feel, and I always tell this to patients, that medicine is a tincture of time. What we know now versus what time tells us is the truth. And sometimes you can't do it in 10 minutes. You can't expect to really understand what's happening until you expand your knowledge. And that has to be by curious nature.
Right, and time.
Time.
I mean, that's the saddest part now, is that if someone has a symptom, you've got to be able to explore that and ask questions. Well, when does it happen, and what does it feel like, and what makes it better, and
Exactly.
how long has it been going on, instead of just saying, "Okay, we're going to refer you to the specialist and let's go get this special test."
Yeah.
And they can't afford it anyway.
Yeah. I call that punting.
Yeah.
The best thing in healthcare now is they punt everywhere, but instead of just trying to solve the problem, they'll just send it off. And it's infuriating, but that's just, if you're not getting paid for it, that's their perspective, then why bother, And that's not why I became a physician.
Right.
I became a physician to care for people. And that's in my DNA. That's kind of, I can't think of doing it, I can't imagine being in a clinic. I can't imagine being in a hospital because it's claustrophobic. I need to just get out and really experience what it's like to be invited into somebody's home and see everything, open up the cabinets, open up the refrigerator, and, fully appreciate their life. And I can say that as a physician, that has imbued upon me a certain sense of the dignity of life, the sanctity of life, to fully embrace my own life as I'm getting older, being there for patients as they transition through hospice, and supporting family members. It's been therapeutic for me. I would say medical school and residency was traumatic in a sense, but it toughened me up. But it's really my patience over time as a house call physician that I've really fully embraced the capacity we all have to care for each other. And I think that's why I get up in the morning. I get all pumped up to ready to go out. And every day is a different day. There are no weekends. There are no holidays. It's another day. And I don't know what's going to happen in that day. But for me, that's exciting. And there's a certain sense of curiosity about, I don't know, let's see what happens, or let's try this, or let's go in this direction. It's, you can't do that in the clinic. You certainly can't do it when you have a administrator telling you have to hurry up. This isn't, we're not making enough. Yeah, it's insulting.
And you have to ask your patient, what do you want? I know for many years I'd say, I don't know everything.
Yeah.
Maybe you'd like to see a specialist.
Yeah.
And refer. And so I tended to do that more in the beginning. And then, and some people would say, sure. Then they come back and say, they didn't tell me anything. They did less than you did.
Yeah.
I don't want to go to any more specialists.
Yeah, yeah. And yeah, that is tricky. We do depend on other physician colleagues to be able to provide additional support for training in their specialty that we may not have or appreciate. I'll actually go out with my patients to the consult so that I can sit there and observe and provide information and educate. Now, I can't do that with every patient, but for those that I feel I really have to, I'll do that. But that's changed so much because the physicians aren't independent. Physicians are part of a larger practice and they have an administrator. So things that I could do even just 5 years ago with a colleague, I can't do now because there are more and more barriers. Even when I try to give a call to the doctor's office, it's like a mountain, trying to climb just to be able to speak. There's barrier after barrier, and you can imagine being a patient. It's infuriating.
Of course.
Yeah. In DC, if you were to try to see your physician, it could take, a regular physician would take 3 months. Well, by that time, either you're dead or the problem's gone away. That doesn't make any sense. Yeah. But what was your perspective also, the transition for medicine, and as a young female physician, what were your perspectives now for young physicians, female are the majority in medical schools, and in certain specialties they clearly outnumber the male physicians. So the whole sense of the old boy mentality has been wiped away. But you give a historical perspective and where you were at and how you may have faced barriers along the way. I'd love to hear more about that.
Certainly, even in pre-med classes, I was often one of the few women. Mm-hmm. I remember taking physics at Princeton, and that's a big deal at Princeton. Okay. But I was using it as a science course. Mm-hmm. Mm-hmm. The first semester there was one other woman. The second semester there was just me. Out of 100. Yeah. The first lab, the professor was sort of in the room, and there were all these tables, and it was a 4-hour lab, and the instruction was design your own experiment about gravity.
Okay.
He said, don't just run around and do stuff. I want you to think. Mm-hmm. Think about it. I was at a table by myself because I didn't know anybody, and so I was sitting there and I was thinking, and probably I was beginning to get an idea, but it had been maybe 15 minutes or so. The professor came over and he pounded his fist on the table and he said, what are you doing? I said, I'm thinking. He was so mad. And he never spoke to me the whole rest of the year. But, and it's hard to say that wasn't necessarily exactly pre-med, but there were many instances like that where, fortunately if people behaved that way or someone called on me without me raising my hand and I felt embarrassed, I didn't necessarily go back.
Yeah.
And so it just, I began to stand up for myself more. And
okay. Yeah.
And then after college, in certain situations where I was volunteering, I was told to do something that I had been taught a certain way was right and another way could harm someone. And I refused to do it. I said, let me go get what I need. And I was told no over and over. And then I just said, no, I'm not going to do that. And I realized that sadly it was a woman who was the head nurse.
Really?
And she was the one that, would have had my head on a block.
Wow.
And even in my internship in orthopedics, the attending was a woman. And I remember one time after clinic, she told me to go admit a patient. I wasn't on call, so at that point at 7 at night, I should have been able to go home. And I said, okay, but you know that your schedule was full. And I wasn't rude. I was always pretty quiet, but I said, it's very unlikely that he's going to ever get a surgery tomorrow, given what they'd already told us was going to be happening. And why are you admitting him now? Maybe it would be better to wait a day. And at that point she said, you are the worst intern I have ever had. You are a disgrace to women in medicine. You are lazy. And at that point, because I'm stubborn, I said, you can call me any name you want, but I am not lazy.
Yeah.
All the men scattered and left me just with her. And, you know, afterwards I left and cried. I was like totally freaked. But I think she was under a ton of pressure, and she had just sort of bought into the way that you have to behave.
Yeah.
And you don't have to just turn around and dump on the lower person.
Sure.
Whoever that is.
Yeah.
When you're an intern, the person to dump on is like the janitor. And I said, no, I'm not doing that.
Oddly enough, I did have some historical perspective. I went to Howard University for medical school, and we had this situation where there was one physician, a female physician, who was brutal, and it was always questioned, why was it so difficult to be a student and learn under her, under this brutal fashion? And what we really came to understand, it was heritage. It had been passed down, and they had assumed the same role for what they had received. And as an African American female physician, just the amount of pressure on her, when everybody was saying, you're going to fail, you're never going to make it, after a while you kind of submit to it, and then you replicate the same behavior. And
I mean, the classic abused become abusers.
Yeah, exactly. And that's so even the way medicine is taught, and the way now it's almost like factory work. You're not meant to be independent. You're meant to be just making sure the factory assembly line keeps going. That's all your purpose is. And if you get outside of that, then you're not going to last. I've been told plenty of times that I'm not going to make it. And I just can't abandon, it. I could have easily said, this isn't right for me, but I knew there was a chord in me that, as a physician, I felt I had something to give to people. It may not be what others people, may want to fashion me to be, but if I stay true to that one, I know over time, it's where I need to be doing the things that I do. And that's where I find myself. So I can lay my head down at night with all the past trauma of being on call and being yelled at and screamed at, and say, I survived it and I'm here now, and it doesn't have to be that way. I think as I take medical students out, it's more of not me trying to put my ego into their heads. I want them to be able to share what their thoughts are, what their passions are. I think also, if you look at other countries and the way medical education is presented, there'll be programs like Cuba is one I commonly go to, where it's a 6-year program, and then it's all paid for. There's no huge financial debt. And when they come out, they already have assignments that then they go on, and it imbues a certain sense of service as a physician to their community. And older Cuban physicians have been some of the most influential to me, in the sense that they are, they're just profound in their ability to communicate, to listen, and have empathy. And that is very much what I take with when I go practice. I'm always thinking of what could I have done differently that really would have connected better with a patient, or given me a better sense of how I can help, rather than hiding behind a screen and trying to tap on a computer just to satisfy the insurance companies. So, but as a female physician, then you also related a story about here when you were setting up your practice. And if you feel, if you want to talk about that, or if you don't want to, that's fine too. But just a certain sense of, how sometimes physicians create problems in supporting something that really doesn't help the situation, makes it worse sometimes. And I say that because, look, sometimes I have to say that my physician colleagues are part of the problem, that they don't stand up and say it shouldn't be done this way. We shouldn't have practice managers saying 10 minutes with the patients. We should be allowed to practice medicine, not practice healthcare. But for yourself, like kind of what were your experiences here early on in the 80s?
Well, I'd always assumed I'd work in a clinic with a group of people. I never thought I'd be on my own.
Really? Okay.
And, you know, I thought that would be wonderful. I'd get to learn from people. I had a bunch of different jobs, and some of them were pretty interesting, and most of the time I was filling in for somebody else or doing a night shift, so I was pretty much on my own. But I had one job here where I was hired as a local physician independent, was going on vacation. And coming back, he found that, I guess a lot of the patients then wanted to see me.
Oh.
I think that was one factor. And so at the end of the month, I was called in and told I was fired. And I remember him introducing me, going up to the local hospital, where you'd have to go up and round on your own patients if you had them in the hospital. He introduced me to one of the surgeons, and that I was going to be taking his place while he was away, so, you know, I might be giving him a call. And the surgeon turned to me and said, "So what are you, a PA?"
Oh. Wow.
And, you know, I mean, that was the general. So when I finally did have the chance to establish my own practice here, because I'd loved it so much working in his office, I went around to the local physicians, and some were women, primary care, some were men. If anything, the men were nicer. I think I said, I'm not here to compete. There are many patients, but I'm going to open a small practice, and I hope we can at least have a good professional relationship, and perhaps we can share call. And they right away said no.
Wow.
One person said, sure, but I'm not going to get out of a four-person group to go to a two-person group. So I did all my own call for the whole time I was on the island, and pretty much after that. And there were times when people expected me to refer, and there were almost all male specialists. There were very few women specialists. So things that I needed to refer on, like to a urologist or an internist or a surgeon, I'd call and ask to refer them, and over time they would refuse my referral.
Wow.
And sometimes really to the detriment of a patient. I mentioned one was an older woman who passed out in church one Sunday, and they called the paramedics who took her to the hospital. They evaluated her. At that point she was conscious and fine, and they couldn't really find anything wrong, but they wanted me to admit her. So I said, I'm happy to admit her, but I'm really not qualified to evaluate her pacemaker. And so could you call the internist on call? And he refused to see her.
Wow.
Because he knew that I hadn't referred patients to him for different reasons at different times. Not because of him, but because the patients wanted to go elsewhere.
Yeah.
And I'm there to assist what the patient wants, to give them a choice. And so he refused to see this person. So they said, well, you can't transfer. You have to come up and clear her before we transfer her. So I did. And I said, everything I can tell looks good. Her EKG looks fine. You know, her blood work is good. She's talking. Her blood pressure's good. I don't know what happened, but I don't want to just send her home.
Sure.
So I think we should send her to her cardiologist. I knew her family. I took care of like 4 generations. They all agreed. I sent her. She got to Seattle without difficulty, but her cardiologist called me up the next morning and was furious that I had sent her.
Wow.
And I said, well, what did you expect me to do?
Yeah.
She'd had a problem with her pacemaker. She could have died en route, apparently. He said, well, refer her to the specialist. I said, I did, but he refused to see her. He at that point said, you need to go talk to the administrator, get your lawyer. And sort of over time, they basically told me I wasn't one of the good old boys. I said, yeah, I'm never going to be one of the good old boys. can't we learn to get along?
Yeah. Yeah.
And
For the sake of patients.
for the patient's safety. Someone walked into my office once at the end of the day who wasn't my patient, doubled over in pain. She had group health at the time. And it didn't take long to say, I think she's got a kidney stone. And so I called the ambulance and I wanted them to take her to the hospital because I had nothing in my office to help her. And so she went up and the urologist refused to see her. So they ended up sending her off island, and sure enough, she had kidney stones. But he was mad because I hadn't sent another patient that his buddy, the radiologist, had said was a urology problem, because he didn't want to go there. So it just, I began to think that this isn't safe.
Yeah.
And then a local doctor bought the building that I was renting in and tripled the rent, and it just sort of escalated that I began to think, for my well-being, I think my dad especially always reinforced that do what you think is right. If you're the only one in the whole world who thinks that way, that's okay.
Yes.
Stand up for what you believe in, we'll support you. And so, you know, especially for young people now going into medicine, at the end of the day, you're the only one there. You have to live with yourself, you have to look yourself in the mirror. If you didn't do what you knew was right, and you bowed to criticism, you're gonna have to live with that forever.
True.
And so it may cause you grief, but it's okay.
Yeah.
And they need people that they can turn to for support and say, you know, I made it anyway, even though I got fired a couple times and I got in a lot of trouble for doing things that I thought were right. I got in the most trouble for the things that I feel like are the best part of me.
Wow.
And
But I think, and that's important for, you know, some people, you know, who aren't in medicine, you know, family medicine, you know, we are, you know, the underdogs. We are very much like dinosaurs, you know, because we don't factor into the economics of healthcare. We're expendable, we're replaceable now, where it wasn't in the past. What do you do, what's a day look like for you as a family physician who does house calls?
so now that COVID's somewhat improved, I'm vaccinated, most of my patients are vaccinated. I try to have a plan where once a week I go do a bunch of house calls. The rest of the time I go up in my home office, I check the faxes, look at refills, look at anything that may have come in from, say, a hospital, somebody showed up in the ER or whatever, or something that I'm thinking about, or I'll get a call from either a patient or a family member or a caregiver. So-and-so, their blood pressure's a little low today, what do you think? So it's really about troubleshooting all day long. Okay, give me this information, how do they look to you? Because most of them are wonderful. They know the patient way better than I do.
Oh, sure.
I mean, I may go in every once in a while, but they're living with them, taking care of them.
Yes.
So first of all, you've got to really respect the people that, and they apologize for bothering me. And I always say, it is not a bother. That's your job. That's what I'm here for. We're working as a team. And then try to make a decision. Okay, let's add this medicine. Could you get a urine sample? Could we add this to the diet? Sometimes it's, okay, give them some potato chips, give them a little salt, because their blood pressure's low, they're not on any meds, they don't have to go to the emergency room. You know, we want to keep people out of the emergency room. We want them to be safe, to be respected. Many of them don't want to go. Even the ones that may, they don't want to be put through every test in the book. And they don't know what's going on. And sadly, many of my patients don't communicate well. They have dementia, severe. And so, you know, I'm partly their spokesperson.
Advocate.
And so, exactly, I'm there to make sure that they're respected, that they're not hurt physically or otherwise. And And much of it is dealing with a family. So the family's scared and they don't know what the options are. And they often think they need to get the most advanced treatment. And I try to explain, this is what I think's going on. This is how we decide. This is what would have to happen. I can't do it. I can come and examine, but I'm not an x-ray machine.
Yeah.
I can't tell what their blood sugar may be, but other things. I can draw blood and I can take it to the lab and they're going to process it, but I'm not going to get an answer right away.
Yeah.
Or if they go to the hospital, they're going to do this and this, and if they find this, which we think it might be, this is what they're going to do next. Do you want that? And most of the time they'll say no.
Yeah.
But when you walk through that process, so you've got to be competent. You've got to think of all the possibilities,
True,
even if
true.
they're not likely.
True.
So everybody thinks if they're a little more confused, it's a UTI. They do not automatically need antibiotics.
True.
But, you know, and sometimes you treat even without getting a urine, because to get a urine is too traumatic. But they then say, okay, it's in your ballpark, you haven't been disrespected, your parent or family member has been respected, they've been given the best possible thinking, and you choose what you'd like for them.
True. And that's the big thing. I would say that we're kind of like Sherpas or guides, you know, and that's very different from other practices in medicine. It's easy for somebody, say, like a specialist hones in on being the best urologist they can be, but people sometimes have a difficult understanding of the role of a family physician and where we are kind of the hub for everything. And the advocacy, I would say, 60% of what I do is social and not so much even medicine. It's being able to work as a team member, like you said, which is, I think, crucial. That we fit in a way to advocate and to guide people through a process that hopefully will have the outcome that we all would want, which if it's an infection, it's treated and they recover and they get better. We are not there to, serve our own purposes. We are there to really be a part of this as a team member, as a member of the community. I think that's where I see myself, is I know that people see me as a team member, as somebody who's there to advocate. And I'll go with my patients. If they're in the ER, I'll sit in the ER with them. And I'll, explain what's going on. This is what we're going to do. We don't need to be here. We can get back out. Or if they go see the consultant, even if it's 2 or 3 different second opinions that we get, that's what we get. So it's, I think people understand, but initially people don't understand that as a family physician, we do more than just be a doctor. We're intertwined, we're all connected. We all share the same purpose, which is to care for each other. And I think that's doesn't factor into healthcare anymore. And there's certainly
that's what medicine is about, though.
Yes.
Is health. Medicine is health,
Yes.
trying to be in good health.
Yeah.
And if you can't communicate, that's a critical part of someone's
Absolutely.
health.
Yeah.
And their emotional health totally impacts their physical health. We know that.
Absolutely. Yeah.
So if they don't have any hope and they don't feel like someone's looking at them as a person and cares, the best treatment in the world may not work.
Yeah, and in healthcare, it's they just write people off. Throw up their hands and we're done. And no, I believe it's a fight. You got to stick in there. And there have been plenty of examples in my life, having seen that. I would say that being able to break outside of the box is challenging because you're kind of against the grain. But at the same time, I get so much more personal reward knowing that I did what was best. And that's, I think that's my legacy. That's your father's legacy, right? And that's what you have as well. We all share that kind of approach to life. Is there anything that you would want to share with people viewing this program, anything from the perspective of you as a physician, but also maybe even as you as a patient? Like, if even from my perspective, I have a better sense of what what I choose to be health for myself. What are my goals? What do I aspire to do to be engaged in being healthy, as opposed to in society where healthcare is about keeping people sick, as opposed to preventing things before they happen, like alternative medicine or things that are not just giving person a pill every time.
So I've always sort of tried to give people options. And I think over time, I ended up having a lot of patients who came with complicated problems. And it was just kind of word of mouth, because they've already had the standard treatment, and someone said, "Oh, go see Heidi." And I know that a lot of some of the specialists would say, "How come we get so many referrals from you and so many patients from you, and you're only one person, and I don't get even as many referrals from like a whole clinic of primary care people?" I said, "Well, it's not about me. It's patients. You know, they have these different things. So, you know, you have to just be open to that. But many don't want typical treatment. So you have to say, okay, this is the advantage. This is a disadvantage of doing something," and they also can't afford it. I mean, the prescriptions, you send them out with 5 prescriptions, whereas I have the luxury, because I have the time, I can say, let's start with this one. Let's start with not the super duper high powered one. Hopefully you need something simple that's generic, that's inexpensive, and it's going to work. And if at any point in 10 hours or 24 hours you're not getting better, or you need something, you can call me back and say, "I think we need to add something," or just say, "I'm not getting better," and I'll say, "Okay, then let's try adding this." So it's about the person and looking at their whole environment.
And it is a process. I mean, there's no quick fix. It's not like waving.
Different.
Exactly. And I think approaching the patient as an individual is paramount, because they need to be engaged, and we need to understand that they have individual needs, but also they have different perspectives. Like the way you perceive healthy, culturally, you're raised in family and everything that determines you. Mine might be different from yours, and sometimes just to even be able to connect with somebody means understanding that they may have a different approach to what health is, and it is about choice. People do choose unhealthy lifestyles. That's their choice, and you can't judge that as a physician. I've certainly been exposed to situations where I'd have a physician colleague comment about a patient's decision and judgmental about it, but I'm like, that's their choice.
They often say, well, I'll give the description, and they'll say, well, you need to fire this patient. I said, I can't fire this patient. I mean, I have to give them choices, but I'm not going to desert them. I can't fix it if they're smoking and they can't breathe. If they don't want to stop smoking, I can only do certain things. I won't make them better, but I'm not going to say I'm not going to see you anymore.
But medicine has become very defensive now. And you assume liabilities that just didn't, But is there anything else that you would like viewers to know? Maybe anything, some perspectives that you have that might be uniquely your own that you think would help them?
Well, I think that hopefully people, when they talk to a doctor or seek health care, even if they've had bad experiences, try to be open. Don't just look at the surface. Don't just look at that, the person in front of you who may look like what you think of as a typical doctor, and okay, I don't trust him. People look at me and say, you're not a doctor, so you don't know anything. Or if I say I can help, they say, are you a nurse? No. So just assume that you have the right to the best care and to be respected. But that doesn't always come in the same form. So physicians should stop judging everybody else, all their patients, for their appearance or their bad habit or their bad health or whatever, or mistakes we all make. But the same, we should try to stop judging each other as healthcare providers, and and work with each other, not get mad if someone made a mistake, or say that's okay. That probably wasn't the best idea, so next time you'll do it differently. We need to support each other constantly. And so for me, that's a lot with caregivers. They have the most brutal job, thankless job. They're not well paid, and they get grief from everybody, no matter if they're doing everything right. And so we all just need to be a little less judgmental and just try to stop and listen to someone before we're assuming something.
True, true. We are, after all, connected. We all share this. We're on the third rock from the sun, screaming through the universe. I think people will talk about division or separation. I don't see how we can be. I think if we share experiences, if we work together, then I think there's hope.
I think everybody really wants the same thing.
I do too, yeah.
They just sometimes get brutalized enough that they are numb to certain things.
Yeah, and sometimes it's easy to fall in a trap, that's all too often.
I know. I mean, and the whole thing with vaccines now, I mean, it's complicated.
Yeah.
And
Very.
it's hard for me. I feel that little rise of energy when a patient says, I'm not going to get vaccinated, but I want you to come here, and I'm not wearing a mask. And, and I haven't ever said, okay, I'm leaving. And I've had to
6
stop.
feet away.
Well, I have my mask on.
Oh, yeah.
So I say, well, okay, I'm doing everything that we've been doing since the beginning to be as safe as we can. And I'm feeling fortunate because I feel more protected. But everybody has their own reasons, and I may not like them or agree with them, but it doesn't mean I can disrespect the person.
Absolutely. No, that's very true.
So we just wrapped up with Heidi, a great family physician doing house calls here in Seattle area. It was great to get her perspective as an older female physician, kind of what she does for her patients and what it's been like. Understanding where she's coming from and what her legacy is extremely important for people to kind of grasp and think about. I would hope it would inspire younger physicians that there are alternatives, that you don't just have to practice healthcare the way it's being fed to you. It does mean you need to be a little bit more proactive and independent, but you can see somebody who's been doing it their entire career, and that passion about caring for people just rings true. That is her legacy. That was the legacy of her father. I would hope that as we explore others who do the same, that resounding sense of duty and service will give people inspiration for what they do. We're heading back now to Everett, just north of Seattle, where we'll be going to meet Bernadette, who's a nurse practitioner doing house calls. She's got a patient with a rash that she's going to take a look at, and hopefully we'll get out there and visit along with her. To find any of this interesting, or more importantly, if you want to collaborate, check out the link below so that you can send us your comments, any stories you may have, anything. We're happy to entertain it, and this is really about us going on a journey together.